Thank you.
Okay, welcome everyone. Welcome to the December version of the JVS Online Journal Club. We want to thank everybody that's here. This is the end of our second year, which is very exciting. We're going to be starting our third year next year. The link to sign up to host has gone out to program directors, but I will also put it into the chat a little bit later for those of you who have not gotten it, so that you can have your programs sign up to host. But for the December version of the JVS Online Journal Club, we are thrilled to have Thomas Jefferson University and faculty and fellows from Wake Forest University. We are going to be discussing two exciting papers: the rates of progression of carotid in-stent stenosis and clinical outcomes. We have our authors, Dr. Ali Abu-Rama and also Adrian Santini. They're here to review that. And then, of course, factors associated with lower preoperative quality of life in patients with chronic limb-threatening ischemia in the BEST CLI trial. I know that we're going to have a lot of different papers coming out of this trial, and we're excited to kind of go through them. And Dr. Richard Powell is here with us as one of the authors from that particular work. Our sponsoring institutions, again, as I mentioned, are Thomas Jefferson University, Dr. Don Salvatore, who is an associate professor of surgery and program director there, as well as Dr. Irfan Ali, who is their first-year fellow. From Wake Forest University, Dr. Matthew Goldman, who is the assistant professor of surgery, and then Dr. Ashley Strusum. And if you happen to be another Ashley who logged in with her link, feel free to change your name, because there are so many Ashleys on this call right now. Sometimes it's a little overwhelming, but she is their second-year fellow. And again, as I mentioned, we have our author guest. This is one of the highlights of this journal club, is that we have authors from the works here to talk to us about their thought process and the outcomes. Dr. Ali Abu-Rama, who is a professor of surgery and chief of division of endovascular surgery at West Virginia University, but also the past president of the Society for Vascular Surgeons. And Adrian Santini is their fourth-year integrated resident. And then, of course, Dr. Richard Powell, who is the chief of vascular surgery at Dartmouth-Hitchcock Medical Center. Finally, we have our two editorial board guests. They will be helping us moderate, and this is Dr. Jesse Manuga at Abbott Northwestern University and Dr. Jean Kang from the University of Maryland. So just some housekeeping details. We do ask that you please stay muted. If you have questions and comments, please put them in the chat. Our moderators will go over those, or they may call on you to also unmute to ask your question if there's some complexity to it. The event is being recorded for on-demand access for those who miss it. And then, of course, we will be having our January JVS Online Journal Club. The sign out for that has gone out. And again, I will be putting the link to sign up to be a sponsor institution in the chat in just a minute for those facilities that want to sponsor a month next year. So I will stop sharing my screen. And with that, we will get started with the first paper.
One of the Ashleys is sharing her screen now. Good. Okay, well, welcome everybody. My name is Matt Goldman. I'm one of the vascular surgeons here at Wake Forest University in Winston-Salem, North Carolina. Thank you for allowing our group to be a part of this, and hopefully we'll get to be a part of it in the future. Obviously, in Winston-Salem, North Carolina, we are in the middle of the diabetes belt and also the home of Reynolds tobacco. So we get our fair share of critical limb-threatening ischemia. And certainly we were anxiously awaiting the results of the BEST CLI trial as well. So the paper that Dr. Stutzram is going to present is one of the first papers off of the BEST CLI trial, looking at quality of life predictors in the BEST CLI patients. And Ashley and I are going to work together. She's going to move the slides forward. So go ahead and move it forward, Ashley. So as we all know, studying peripheral vascular disease is actually one of the most difficult patient populations and disease processes to actually study and to design good trials to evaluate outcomes. And there's a lot of reasons for that. Obviously, the heterogeneity of the patient populations is profound, with so many different risk factors for PAD, that it just creates a very complex sort of web of risk factors as well as outcomes. The treatment of peripheral vascular disease and critical limb-threatening ischemia also bridges across multiple specialties. Fortunately, in our institution, predominantly vascular surgery is intervening on these patients, but in a lot of parts of the country, it involves interventional radiologists, it involves cardiologists, it involves podiatrists, it involves orthopedic surgeons, nutritionists, endocrinologists. And so there's a lot of specialties involved in the care of these patients, which really makes honing in on specific questions and outcomes somewhat difficult sometimes. Another difficulty in studying this disease process is that there are multiple intervention modalities. We have open interventions, we have endovascular interventions, we have hybrid interventions, we have medical therapies. And so the dynamic between these interventions and the multiple different ways to approach the problems with these patients can make studying these patients and their outcomes difficult. Another difficulty when you try to study patients with critical limb-threatening ischemia is that the technology is continuously changing. Obviously, I was a fellow when we started enrolling patients in BEST CLI, which was over 6 years ago, I think. And certainly technology has come a long way since then with drug-coated balloons and now intravascular lithotripsy and alternative conduits and better pharmacotherapies. By the time you get to an endpoint of a trial, you're already 5 or 6 generations down the road of new technology coming out. And so we're somewhat behind the curve all the time with keeping up with the latest technology when we try to study these patients. Along those lines, there's also technology improvements in the outcomes of these patients, and specifically with rehabilitation and prosthetics and the ability to make these patients more functional earlier. And so that obviously plays into quality of life, undoubtedly. So it begs the question, which outcomes are important? And I commend the authors of this paper because they look at an outcome that is not necessarily routinely focused on when you go to vascular meetings. If you go to the next slide, actually, we've kind of just pulled up some of the landmark trials looking at peripheral vascular disease. And if you look at the outcomes in most of these trials, it's usually mortality, and it's limb salvage, and it's primary and secondary patencies. Actually, you can keep clicking through. So if you look at, the Zilver trial from 2016, again, freedom from ischemia, freedom from reintervention, freedom from target lesion revascularization, and then limb salvage. And that's a recurrent theme when you look at outcomes from peripheral vascular disease research. We are very focused on limb-specific outcomes in a lot of our research and restenosis outcomes in a lot of our research. And so I commend Dr. Powell and the group that wrote this paper because they looked at more patient-centered outcomes, which as we move forward, certainly in a value-based care model, the patient-centered outcomes are most likely the ones that are going to drive our care moving forward. And so when we start to talk about research for peripheral vascular disease, we ask the question and we look at limb salvage and we look at freedom from reintervention, and certainly cost has become an important question now. But quality of life is really what we're looking for with these patients, right? And patient goals are really what drive or should be a part of what drive our decision-making in the care of these patients. And what this paper starts to do is it starts to look at what factors affect the quality of life in PAD patients. And if you were to take it one step further, then what we're really trying to get at is what are patient goals? Because obviously patient goals likely affect their quality of life. And if you go to the next slide, Ashley, this is a question that certainly my mentor, who used to be here at Wake Forest, who's now at the University of Michigan, Matt Corriere, has had an interest in for a long time. And Dr. Humphreys probably doesn't remember this, but she commented on this paper at the VESS, where we actually were looking at how many interventions and whether interventions play a role in quality of life for these patients. And then more importantly, if you were to extrapolate from that, really what we're trying to get at is, can we provide a treatment that is consistent with what the patient goals are? Because ultimately that may affect their quality of life. And I think Dr. Powell and his group have started that process with this. The BEST CLI trial was a huge undertaking and a robust trial to gather a large cohort of patients that's going to allow us to at least start to crack this nut of really goals of patients and trying to make our treatments match their goals, which hopefully ultimately will lead to a better quality of life. And the anecdotal example, especially with diabetes becoming more prevalent, we're dealing with tibial vessel disease a lot more with interventions that have worse outcomes sometimes with tibial disease. And so sometimes the question of is the goal to be functional in 3 months may not be a limb salvage outcome. It may be a primary amputation outcome. And so I think this paper starts to ask that question about, can we target the things that matter to our patients when we offer them interventions? So with that, I will turn it over to Dr. Stutstrom to present Dr. Powell's paper. Again, thank you for allowing us to be a part of this. Looking forward to hearing the commentary.
Thanks so much, Dr. Goldman. Really great introduction to this good paper. And again, thank you all for this opportunity. Just kind of some background in looking at quality of life. Two big studies are the BASIL and the PREVENT-3 trial, which were multi-center randomized studies. And these are evaluating quality of life in CLI patients. However, both look at quality of life after intervention. And so the BEST CLI trial, the goal is really starting off to evaluate quality of life preoperatively. So just background reminder, BEST CLI is a multi-center randomized controlled trial that looks at best endovascular or best open revascularization for patients with infrainguinal occlusive disease who have both open and endovascular options. It was a superiority study that was looking to compare the primary endpoint of major adverse limb event-free survival. But again, a secondary endpoint was health-related quality of life. This was assessed with the Vascular Quality of Life Questionnaire. This is a vascular-specific questionnaire looking at quality of life, as well as the European Quality of Life 5-dimension and short form 12 surveys. These are not vascular-specific questionnaires, but they are validated measures of quality of life. So the objective was to provide a contemporary assessment of health-related quality of life in patients with chronic limb-threatening ischemia or CLI, and to identify predictors of poor health-related quality of life at presentation. So these questionnaires were completed after signing consent for BEST CLI, but again, before revascularization. The mean vascular quality of life was compared using t-test statistics, and multi-predictor regression models were used to evaluate for correlations between demographics and health-related quality of life measures. These models adjusted for race, age over 80 years, gender, heart failure, above ankle amputation of the contralateral limb, bilateral CLI, COPD, smoking status, end-stage renal disease, hyperlipidemia, diabetes, hypertension, tissue loss, opiate use, comorbidity index, ambulatory status, and if patients lived at home. So there were 1,830 patients that were included, and great responses. 95% completed the Vascular Quality of Life Questionnaire, 96% completed the European Quality of Life 5 dimensions, and 96% completed short form 12. The baseline characteristics are seen here. Mean age in brief was 67 years, 28% were female, 28% non-Caucasian, 22% had ischemic rest pain, the remainder having tissue loss. 16% had bilateral CLI, 44% were current or past year smokers, 7% had major amputation of the contralateral limb, 14 had a prior intervention on the index limb, 69% were diabetic, and 11% had end-stage renal disease. So when looking at the results of the Vascular Quality of Life questionnaire, it was found that female sex, history of either current or within the past year smoking, opiate use, or ambulatory status were associated with worse vascular quality of life scores. And interestingly, the quality of life scores were compared to the BASIL and the PREVENT-3 trials, because they also use this questionnaire. And what the authors found were that the vascular quality of life scores trended lower in BASIL, although not statistically significant, but they were significantly lower in the PREVENT-3 trial. When looking at short form 60R2, which is an cumulative index measurement of a composite of both physical and mental health scores that are captured by short form 12, it was found that the short form 6 scores were lower at presentation for, again, female sex, patients who had history of current or within past year smoking history, opiate use, and impaired ambulation. When looking more specifically at the breakdown from short form 12, which is the mental health composite score, they found that, again, this is significantly lower for younger patients, female sex, current or within past year smoking, opiate use, as well as ambulatory status. For the physical health scores, these were interestingly significantly improved for Black race compared to white, and then significantly worse for current or within the past year smoking history, opiate use, or ambulatory independent, non-independent ambulatory status. For the European quality of life 5-dimension scores were lower in patients with bilateral CLI, current or within past year smoking history, or impaired ambulatory status. Importantly, this instrument did not demonstrate any difference based on sex. So in going into the discussion of these different instruments and what they found, importantly in this study, the short form 12 scores were 2 standard deviations lower than the general population. So in 2018, for patients over 60, the general quality of life from short form 12 was 46.5 versus the mean score for best CLI, which is 33. And this is consistent with other studies that have shown CLI patients have short form 12 scores that are similar to patients suffering from cancer with multiple comorbidities. So again, the patient specific characteristics that predict significant negative impact of CLI on health-related quality of life at presentation that were consistent across 2 or more surveys included female sex, history of current or within past year smoking, opiate use, and impaired ambulation. So interestingly, previous studies have also confirmed that female sex is associated with worse quality of life scores at presentation. They have attributed the physical composite scale score to be more so affecting the decreased quality of life for females as compared to the mental health composite scale score. But in this study, the mental health composite scale score was dramatically decreased. And it's unclear if this is due to more virulent disease in women or later presentation, as we do know from other studies that women tend to have a lack of family and social support mechanisms and seek medical attention at more advanced stages of disease. Again, for smoking, consistent with previous studies where we see that smoking is associated with lower health-related quality of life compared to never smokers. And importantly, previous studies have showed the magnitude of the negative relationship between smoking and lower quality of life is related to the number of cigarettes smoked. So the authors recommend smoking cessation strategies should be employed to treat this modifiable risk factor. Similarly, opiates were associated with worse health-related quality of life. This is likely, the authors say, a marker of severity of CLI based on adverse side effects and those associated with opiate use. They recommend minimizing opiate use. In terms of ambulation and contralateral major limb amputation, this was associated with improved quality of life score when measured by the vascular quality of life in short form 6 surveys. Interestingly, patients with contralateral critical limb ischemia, though, had worse health-related quality of life scores when measured by the European quality of life instrument. And decreased health-related quality of life was demonstrated in all 3 instruments when associated with decreased independence. So the recommendation was to pursue aggressive wound care to facilitate ambulation because this may result in improved independence. So some limitations of this study, I thought that it was interesting that race was associated with lower health-related quality of life in all of these instruments pretty much, but it wasn't really included in the discussion. I was just kind of curious about that. And I think the authors point out that opiates have a lot of side effects and we should work to minimize their use because of that. But also this is a marker of severity of disease. So I'm not sure that it's exactly a causality kind of a thing so much as the authors point out that it's more of a marker of disease severity. But I think as Dr. Goldman kind of discussed in the beginning, I think an overall limitation of where we currently are in the tools that we have available when trying to evaluate quality of life is that it's really difficult to provide a real granular understanding of the quality of life for an individual because those individual patient goals are so unique. And so I think this is highlighted in the study, and the authors point out that we need further study to understand this, and that we see worse quality of life with impaired ambulation across all of these instruments. However, we see worse quality of life associated with contralateral CLI with one instrument, but improved quality of life with contralateral amputation in 2 of the instruments. So I think this just highlights there's something else there in terms of the patient's individual goals that we're just not able to capture quite yet. And that is going to be really important in helping to individualize our goal for our patients. So conclusions of the study are that patients entering the with best CLI have very low health-related quality of life scores, comparable to patients suffering from other chronic conditions characterized by physical limitation and chronic pain. Smoking, impaired ambulation, opioid use, and female sex all predicted lower health-related quality of life. Thanks again so much. We're so glad to be able to participate in this journal club.
Great.
Thank you. Oh, perfect, Jesse. I was going to say, if you want to take over, go for it.
Yes, thank you, Ashley, and thank you for you guys for, this is really an important question. I think we are raised or we trained to look at results, angiographic results. So great, you know, the SFA looks wide open and popliteal looks open, tibial look open, but the most important thing is really the quality of life. How have we really impacted the patient's quality of life going forward, because they don't even know what it means, what SFA means, what a popliteal artery means. They just want their wound healed. So I commend the authors for this. We have very, very important questions. I just wanted to kick off by asking Dr. Powell, did you look at the difference in the quality of life? Was there any difference between the patients who underwent open revascularization versus those that underwent endovascular revascularization?
Do you want me to go ahead and start and answer that now?
Yes, please.
Okay. Sure. So that, you know, this, I'm sure when people saw this, this manuscript, they're probably disappointed because, you know, everybody wants to see whether surgery is better than endo. But so this trial, I mean, this paper really sort of is more of a paper to sort of level set how bad off CLI patients are. So they're, you know, the next paper that's going to is sort of in the process of being written is looking at, you know, what happens to the patients over time when they're treated, you know, with open surgery and endovascular treatment. Did their quality of life scores improve? How much did they improve? Which one improved more? And were they sustainable over time? And those that, you know, Matt Menard published or reported that at the AHA meeting in November, and that manuscript's in the works. This particular manuscript, I mean, you know, you really, what we wanted to do, you know, like, so when you write a paper in the future about, or you design a trial in the future, this would be a good reference to show how bad off the patients are, you know, when you're starting, and why, you know, that their quality of life is so bad that this is really a significant unmet, you know, public health need. And we use three different quality of life measuring tools. One sort of disease specific, VASQUAL. And then, but you always, if you use a disease specific quality of life measure when you're doing a trial, you always have to use a general quality of life measure to make sure you're not improving like the disease specific quality of life, but hurting their overall general quality of life. And so we picked sort of the most commonly used one, the VASQUAL, SF12, and EQ5D. And the other thing we picked all three for was because, you know, if you look at enough variables randomly, you're going to accidentally have some that pop up as being significantly different, just because you're looking at so many variables. And so what we really wanted to focus on were variables that we saw consistently higher or lower across, you know, two out of the three tools that we used are 3 out of the 3. And that's why we focused more on, like female sex was, more common in 2 out of the 3, opioids, not able to walk, smoking was 3 out of the 3. But things that just popped up singly in one of the tools, but we didn't see it in the other tools, we were less focused on because you can't, that could just be, sort of a random event because of the number of variables that we were measuring.
Okay, next question is from Dr. Carlos Bashara. It says, if I believe this is the results, when you report that the quality of life was really the result of a more virulent disease, was related to a more virulent disease, Dr. Bashara wonders, why were patients with bilateral critical limb ischemia not have the worst quality of life?
Yeah, I think, CLI is a pretty generic, there's a wide range of CLI in, without having the hemodynamics in front of you or their degree of tissue loss or, so you could have one patient with bad CLI in their leg they're getting in the trial for with bad tissue loss, toe pressures of 0. Then you could have another patient, with bilateral CLI, but their toe pressures are 30 and they've got some rest pain. So I think that, I don't think that it's hard to quantitate exactly how bad their CLI is. Certainly it didn't pop up repeatedly in multiple different health-related quality of life measures. And I think Alec Farber may be on the call. I haven't seen him, but he said he was going to try to call in. He's the senior author of the Best CLI trial, or the senior PI, and he may want to weigh in as well.
Dr. Farber, are you on the call? If not, I think Dr. DeMuzio's question was probably answered with your first answer, answer there. I'll go to Misty's question. Says
I saw it, that's why it was so long-winded.
Yeah, says with these outcomes, do you think there are certain intervention we should focus on when we discuss treatment for patients with critical limb ischemia, threatening limb ischemia? Do we need to focus on post-procedure mobility with rehab and PT?
Yeah, I think that's a great, mobility. I think Misty is spot on. Because mobility is even more important than living at home for patients. Living at home, it was interesting, like living at home did not pop up as significantly positive or negative, but not able to walk, it was huge. That was like the number one, that was like the one that had the biggest impact on patients' quality of life. And I think her idea, around prehabbing them by getting them into physical therapy before their surgery and being very aggressive about maintaining their mobility, especially for the tissue loss patients with like orthotics and whatnot, I think is probably one of the big take-home messages, from this work. I think that it was pretty insightful.
And this is a loaded question from Matt Goldman. And I encourage everybody to weigh in. It says, is wound healing truly the goal for all patients? I would say so, but so it goes on, said wound healing involves offloading, multiple office visits, hyperbaric oxygen, and often multiple encounters with healthcare system and likely multiple operations. True. Some patients' goal may actually be free of healthcare system. How do we get free of healthcare system if we have wounds? Be mobile, and sometimes a primary BKA may provide that. And this is also true. It's patient's goal, right? Maybe we should be respecting the patient wish rather than saying, hey, you got critical limb ischemia, you have an intervention. Should we be offering primary amputation?
Yeah, I don't know the answer to that question based on this data. For the best CLI quality of life, the manuscript that looks at what happens over time as far as, how the patients get better with their intervention. One of the subgroups that we're going to look at are going to be what's the quality of life of patients who receive amputation. Because, you know, if the patients who get amputated have really bad quality of life scores, then we know that's probably an avenue we don't necessarily want to go down. Whereas if they have good quality of life scores, then I think, you know, then we might think more about amputating sooner, and, you know, depending on how well we can rehab them.
Very good. Thank you so much. I wish we had more time. There are more really interesting comments from Dr. Bouchard here. And other folks, I'm sure, have a lot of questions. This is a very important paper. As we said, we're going to get more papers from this important studies. We were personally involved. I have other questions about the whole trial and other things. I'm sure we'll have an opportunity to ask those. So we'll transition to the next paper. Thank you again.
Thank you very much for asking us to attend. It's great. This is Journal Club's great, and we appreciate being asked to help with it. Thanks.
You see my screen? Can you see?
Yep,
Yes.
looks good, Dawn.
Hi. Hi, thank you. I don't always sound like this, so my apologies. Thank you for allowing us to host this and discuss this next very interesting paper about carotid in-stent stenosis. So just a brief overview of this is known to pretty much everyone on this call, but I figure there's quite a few trainees, so I would just discuss briefly. Stroke is the third leading cause of death in our country and #1 cause of disability. It costs our country about $30 billion per year, and long-term stroke survivors generally are not returned to fully independent living. 85% of strokes are ischemic. And to that end, a good percentage of ischemic strokes are related to carotid bifurcation disease. 20% of anterior circulation ischemic strokes are related to carotid stenosis, with a significant 30-day mortality and 5-year mortality related to carotid territory strokes. So carotid artery disease, the overwhelming majority is related to atherosclerosis, and a smaller percentage is related to other non-atherosclerotic lesions, such as fibromuscular dysplasia, other vasculopathies, and dissection. So historically, the first recognized report of that extracranial vascular disease can be linked to stroke was in 1875 by Dr. Gower. Then jump forward to 1914, where Dr. Hunt recognized that extracranial carotid artery occlusive disease was a possible cause of stroke. In 1937, Dr. Monet started performing carotid arteriography to diagnose carotid artery occlusion. And then in the early to mid 1950s, the first carotid endarterectomy was performed in a patient who had TIAs. Then in 1981, Dr. Matthias in Germany performed balloon angioplasty at the carotid bifurcation. Then over the next 2 decades, there were broad advances, lots of people working different places, thinking of different ways that you could intervene on the carotid artery endovascularly. Thus, in the 90s, we began with the use of embolic protection devices, realizing that ballooning and stenting the carotid artery, if there was distal embolization, how significant the implications could be. In actuality, a carotid stent was first used in 1989 for actually a carotid intimal flap. Then as we got into the 1990s and the early 2000s, the use of stenting in the carotid artery was used more widely. And this is one of the most studied areas in medicine, specifically comparing carotid endarterectomy to carotid stenting. Then in 2012, TCAR was developed and introduced. So our conventional carotid endarterectomy is open surgery. As shown here, you expose the carotid bifurcation, perform an endarterectomy. Sometimes a shunt is used depending on cerebral monitoring intraoperatively, and then most people close their arteriotomy with a patch. Then we also have eversion endarterectomy, as shown here, where the internal carotid artery is actually transected at its origin, and a careful eversion endarterectomy is performed. So then transfemoral stenting, as you might imagine, or as you can see, has a long way to go. You have to access the femoral artery, you traverse the aorta. Then you have to navigate sometimes these more complicated aortic arches to get a wire and catheter up into the internal carotid artery. As you see here, this is one version of embolic protection device. In the past, we used to pre-dilate the carotid artery, not so much anymore. For the most part, we just put a self-expanding stent in. And this is a wide array, as industry drives a lot of things that we do to some degree. That's good and bad. This is a wide array of different embolic protection devices. And then as shown here, the more current and probably a safer way to perform carotid stenting is TCAR, transcarotid artery revascularization, where the concept uses flow reversal, a cut down on the carotid artery. The carotid artery, common carotid artery, is accessed, and then there is a tubing connected to the femoral vein through percutaneous access. And then at the time that the stent is implanted, flow reversal is instituted, and then once that is completed, flow reversal is stopped. And you can see here the embolic material that is collected. And just moving forward, when we were talking, more relevant to our paper now is in-stent restenosis. This is one version of how carotid duplex is used to measure the degree of carotid stenosis. As we all know, interventions are offered to people who have symptomatic disease over 50% stenosis or asymptomatic disease over 80% stenosis. And in patients who have had intervention, including carotid artery stenting and carotid endarterectomy, the criteria determining what is considered significant disease is a little bit different because the vessel is less compliant, and we use higher velocities to determine if there is more significant disease. And finally, artery interventions go, the choice of therapy, including best medical therapy, which should always be on the forefront before we offer intervention or as an adjunct intervention. Although standards exist, patient selection is critical, and when and how to re-intervene requires careful follow-up, patient selection, and remains in flux. Thank you.
Right. Thank you for that introduction, Dr. Salvatore. My name is Irfan. So the paper that we're presenting is, as stated here, the rates of progression of carotid in-stent stenosis and clinical outcomes. And so as part of the background for this paper, appropriately, it noted that the rate of recurrent stenosis after transfemoral carotid artery stents have been reported in the literature from 1 to 30%. And so in terms of actually being able to report some of this data, the most common modality used is carotid ultrasound. And so the thing that was pointed out within this paper is that stents themselves can actually decrease the compliance of the actual artery, thereby elevating the peak systolic velocity that is seen within the vessels. Another thing that was pointed out within the introduction of this paper is that secondary analysis of pretty important study, the CREST trial, noted that there was no significant differences that were present in the instance of in-stent stenosis to the time intervals of 2 and 10 years after carotid artery stents as compared to carotid endarterectomy. And so to this end, in terms of development of in-stent restenosis after carotid artery stents, there are a few factors that could play a role. And of those, one that prominently has been sort of discussed and something that should be considered as neointimal hyperplasia within the actual stent struts. It does, the paper does make a pretty good point of pointing out concomitant factors such as diabetes, dyslipidemia, as well as female gender may also have a causal role in terms of in-stent restenosis. And then goes further on to, talk about the EVA 3S trial in terms of in-stent restenosis as defined as greater than 50% on ultrasound. And this was demonstrated at 2 years to be about 11% compared to 5% in carotid artery stents compared to carotid endarterectomy. However, analyzing the rates of progression of in-stent stenosis, studies really looking at this question have remained scarce. So the purpose of this present study was to analyze the rate of progression of in-stent stenosis and really the clinical implications at later follow-up. So in terms of the actual study design, this was a follow-up on a previous paper that had been published in 2019, where clinical data as well as information had been taken from there and extrapolated and had been studied. So it was a retrospective review on prospective data where they looked at progression of carotid in-stent restenosis at the longer follow-up greater than 10 years. And the intervals of carotid duplex was done at 30 days, 6 to 12 months. And the specific criteria there is shown where if you had greater than 50% in-stent stenosis, you repeated it in 6 months. If you had less than 50% in-stent stenosis, your follow-up period for ultrasound was 1 to 2 years. In terms of the actual design, about 446 patients were used, of which 406 had their first duplex that showed less than 50% stenosis. And then from there, it was subdivided into groups where it was 324 did not progress. And then 82% or 82 patients rather progressed to greater than 50% stenosis. And beyond that, patients had a duplex greater than 50% were subdivided into a separate category, of which 107 patients did not progress from a moderate stenosis, and 14 of those subgroups progressed from a moderate stenosis to greater than 80% stenosis. To this end, the information was sort of looked at in a granular detail where the actual examination of in-stent stenosis progression from less than 50 to greater than 50, that moderate stenosis to less than 50 to greater than 50%, but less than 80%, and then neurologic events from this were examined. And you can see information here as presented in terms of neurologic events, TIA, strokes, or happened, a minority of the time, but recurred at a pretty low rate within these specific subgroups that were analyzed. And to this end, in terms of supplemental data, in terms of the rate of progression and timing of when some of this information sort of presented itself when these patients were examined, it was really the paper made a very good point of between 1 to 24 months as we saw the majority of the in-stent stenosis from less than 50 to greater than 50%, and subsequent from greater 50 to 80%. And then from there, also the time of re-intervention when you saw overall time to greater than 80% restenosis was about 50 months. And then a few months after that is really when you intervened, and that was what was seen within this data set. So overall, I think the more important point here is the overall instance of stroke rate within these groups really yielded some important information. Is that those that had progression to a higher rate of 80% in-stent stenosis, those were younger individuals. So the age that was quoted for restenosis at greater than 80% was 63 compared to those that did not progress, which was about 69 years old. And so in terms of re-intervention, the groups were analyzed in terms of what was actually done to intervene. And so to this end, 28 patients within the group analyzed had a repeat of their procedure in terms of stents, 3 of which had TCARs, but a majority had transfemoral carotid artery stents. 3 had repeat surgeries, and 3 just had balloon angioplasties. And then progressing from taking a look at the data in terms of freedom from stenosis, so greater than 50% stenosis, freedom from stenosis at 5 and 10-year intervals, which I thought was an interesting sort of way to look at this information. You can see greater than 50% stenosis freedom from restenosis was about 70% and then 60% respectively, and then subsequent to that, greater than 80% stenosis freedom from that was about 91% and 84%. And so the paper goes on really to discuss, that despite the fact that we have carotid duplex ultrasound really to examine as to, what is the rate of progression of this in-stent restenosis, it really remains a relatively benign disease process. And so to this end, the CREST trial did make a point that you have a greater risk of ipsilateral stroke within the peri-procedural period. But that being said, that sort of like dropped off as time went on, and then looking at the meta-analysis of multiple studies that examined carotid artery stents as well as endarterectomies. You had, rates as high as 10% stenosis at 5 years, or greater than 7% stenosis in 10% of the population at 5 years. But the minority of the time, only one case of those patients examined had a stroke on the ipsilateral side. Within this paper, I think the salient point here is that although you had a progression of in-stent restenosis, about 20%, in a similar sort of fashion, this was associated with a very low risk of latent neurological events, about 0.4%. And so there was a nice article from 2021 that really by Dr. Abu-Rama's group that really kind of went through all the information in terms of carotid artery stents, carotid endarterectomy, recommendations, guidelines, and really the overall broader impact on like the healthcare system and how we take care of these patients after index operation. There is a lot of emphasis on aggressive medical management and optimizing these patients, especially after they're treated. And I think within that paper and within this paper itself, the role of duplex surveillance, although it is widely used and there are different modalities and different, sort of ideas as to how aggressively to use it, I think the reevaluation of how effective it is in terms of overall surveillance and its cost effectiveness in surveillance, I think should be examined. And that's what this paper states. And so the limitations within the study is that, it doesn't have some retrospective, it is a retrospective study, but, there is a possible bias from the inclusion data, but I think they did a reasonable job of making sure that it was as objective as possible within that data set. And then the other side of it is that, another limitation was any sort of like angiographic verification of in-stent restenosis. Although, again, in a previous paper that was published in 2019, there was criteria that's stated here on the slide from Dr. Abu-Rama's group that really looked at a standardized way of looking at PSV in terms of how it relates to a degree of stenosis. And I think that it was done in a very standard sort of way that made a lot of sense. I think that a question, especially from like my side, would be in terms of looking at the data and looking at the patients examining the timing of these TIA and strokes as it relates to these subgroups, greater than 50% stenosis, greater than 80% stenosis, I think would be, a logical next step in really kind of getting a bit more granular detail and kind of helping define when we use ultrasound. And I think that was a small point that was made in the beginning of the paper. And that was just my personal sort of perspective. Thank you very much for the opportunity.
Great, thank you for a very thorough presentation of this paper. Dr. Abu-Rama, I have a question that maybe you can help to clarify. So when you are looking at the degree of in-stent restenosis at the time of the neurologic event, is that the degree of stenosis at the time of the neurologic event, or was it based on the previous surveillance study? If the answer is it was based on the time of presentation of the neurologic event, when you look at the previous most recent surveillance, did you see any increased risk of progression when these neurologic events occurred?
Actually, that's an excellent point. If you look in the manuscript, we define the symptomatology that we felt need to be correlated to anything within roughly 3 months to less than 6 months. I mean, the patients give that onset of, let us say, TI or having stroke, as long as within 3 but less than 6 months of the time of the examination of the ultrasound, we consider this as a symptomatic, whatever, above 50 or above 80. This is how we consider. So, and in my mind, that's probably extremely critical point, because what matters really is this, to be honest with you, because I noticed 2-3 questions already being placed. Out of the 445, and that's what I wish everybody listen to it carefully, only 3 patients have strokes from the people who progressed to the above 50 or above 80. And incidentally, one of them was contralateral stroke. And what does this mean? Of course, there were around 8 or 10 TI, it depends whether above 50 or above 80. But you and I know if someone comes with TIA and they call you or call me, first thing we're going to do, we're going to get an ultrasound. and we manage it according to that ultrasound. What do we do next? Therefore, it doesn't really help me very much to do the ultrasound. I'm trying to prevent the TIA, because the TIA, when they have, he's going to come and tell you, I have a TIA last week or today, and we're going to do, you're going to order the duplex ultrasound. The one which bugs you and I are the one which they came with a stroke, and we have not detected them at the time of the ultrasound of that stroke. And that's only 3, 1 contralateral and 2 ipsilateral. And that's why by the end of the paper, I was saying, perhaps we need to really sit down and decide, do we justify doing all these ultrasound so we could prevent a 2 ipsi, and probably we're not going to prevent the 1 contralateral stroke either. Yes, I hope that answered your question.
Yeah, it did. And I think it also addressed Dr. Brian Beeman's question. The question was, so if carotid duplex ultrasound is unlikely to change our management or identify those who develop symptoms after CAS, why are we checking these so frequently? And so
That's an excellent point. And incidentally, forgive me, up 3 years ago, when our SVS writing committee put the guideline for post-intervention surveillance, if you remember that very well, by Zieler and his group, actually in my comment, I did not agree on the carotid recommendation. Why? In my mind, not only there's no level 1 evidence or strong evidence to support it, I just felt we are doing it really without strong justification or evidence. It's totally different, as you know, after a bypass, whether lower extremity or aneurysm, but after carotid, particularly carotid stenting, because with the carotid stenting, every data is telling us 95% plus are these benign processes. And that's why in our guidelines, we are telling everybody, do not do an intervention unless it's really, really not only so progressive, but that's the only artery with that patient, and of course, they are symptomatic. So why would I do all these ultrasound? And you talk about 445 in our case, and we average around 4 or 5 mean number of ultrasound, multiply in my institution $400-500 for the ultrasound. You talk about $2-3 million, which may help us prevent 2 stroke, which I'm not sure it would. This is my recommendation. Paul, I need to ask you something. Is it, I don't know about your rationale or how you approach your journal club. Is it good idea to refine some of the little introduction which already been done? There are 2-3 comments. I'd like to refine it if it's allowed. If not, I'm going to forget that and I will give you my note later on.
Go for it.
Because it's good for the junior. It just bothered me for exam purposes. And I do apologize in advance if anybody take it on the wrong side. It happens not only at written guidelines, my life has been cerebrovascular disease. The incidence of carotid disease, bifurcation disease as a cause of ischemic stroke, most best recommended references give you between 10, 20, and if you are very liberal, 30. So I like to see the number to be 10 to 20, but definitely not a 30%. Number 2, as a cause of death, the third cause of death was over 10, 15 years ago. The latest data from the American Heart, based on where you read in the last year or 2, it moved from the 4th to the 5th as cause of death, not the 3rd cause of death either. And finally is the cost. Unfortunately, the cost used to be $30 billion also over a decade. The latest numbers range between $60 to $70 billion, the cost of stroke in America. And the last comment is, I'm not sure hardly anybody use the University of Washington criteria anymore. So be a little bit more updated. Either you go with the consensus or you go with Abrama's criteria or you go with the newest IAC criteria which just published 6 months ago. I'm not sure the University of Washington criteria can be validated today on what we do. And I hope to God that will be helpful to everybody. I'm still open for any question or comment.
There's another question from Dr. Ben Pierce, Dr. Abrama. Other than age, were there any other factors associated with progression, such as symptom status at time of initial stent or peak systolic velocity of initial post-stent study?
That's an excellent point. We did not look into this study, but in the previous study over 19 years ago, when we validated our duplex velocity criteria, the findings of in-stent restenosis was almost mirror image to restenosis after endarterectomies. Not only female gender, size of the arteries, diabetes mellitus, and of course, smoking was somewhat as a factors. So I did not specify on this study on what specific risk factors was predictor of in-stent restenosis. And between you and I, forgive me, the fact of the matter for the whole this paper, this article particularly, is to tell people, please, please, please be selective in your post-intervention. Therefore, I'm not sure, even if we came out with which factors might predict in-stent restenosis, if we're not going to have any trouble from it, then I'm not sure it's going to make a difference in this scenario. Yeah.
I think Dr. DiMuzio, did you want to ask your question about the medical management change with in-stent restenosis?
It was just simply, we may not re-intervene, but oftentimes I keep them on Plavix for 3 months, revert to aspirin and statins. But if I do see a restenosis, I might add back Plavix. So yes, I am very loath to re-intervene on in-stent restenosis as outlined by everyone here. But it might change medical management. I don't have any data on that other than to makes me feel better.
That's an excellent point, Paul, but you and I know this, and all of the people on this probably audience realize you have to optimize medical therapy regardless of what stenosis we have, because sooner or later you're going to have some disease somewhere else, whether coronaries or PADs. But if it makes you feel better, it makes me feel better too also. Absolutely, Paul. Yes.
Doctor, if we have time for one more question, Dr. Moninga had a question. What intervention are the authors recommending for patients with symptomatic in-stent restenosis?
First time I would re-stent or re-balloon. It depends on what type of stent, whether localized or extensive and so forth. There are some data, mainly from Europe, which I listened to it when I was in Rome at the European meeting. They are much more aggressive than us. They are even going all the way to lithotripsy with or without a filter. I do not believe I would recommend it at this stage till I see better data. And of course, if the patient is symptomatic and you feel it's difficult to re-stent, you might have to go and just take the whole segment off and replace it with interpositional graft. But that's what I would do. But first is first. If it was done endo, I would give it re-endo in the second time.
I don't know if this data is from after in-stent restenosis after CEA, but I think there's some data that suggests that like redo carotid stenting has higher incidence of recurrent restenosis than doing a redo CEA. Is that?
It is, that's absolutely my own philosophy, probably agree with you, but believe it or not, probably 80–90% of the younger generation will not like to even think of doing a redo endarterectomy after a stent, not after benign. But logically, I agree with you. I think most logically, this is what makes sense, but I wish I could give you strong data to support this.
Mm-hmm.
Yeah.
Yeah.
Well, thank you. We had such a lively discussion in so many different areas that we uncover and understand about the research, and many questions that we still have to answer. So we want to thank everybody for being here for the December version. We wish everybody a happy holidays, and we're looking forward to the start of the new year and seeing everybody back in January. Have a wonderful night, and thank you to our authors, our guests, and our presenters and sponsors tonight.
Thank you, Mitzi and Paul, and it was really great pleasure being with you guys. Thank you very much. Happy holidays.
Thank you, everyone.
Thank you.
Thanks. Good night.
Good night.
Ciao, ciao. Bye-bye.
Okay.
Thank you.